Welcome, ladies and gentlemen. I hereby officially open this academic ceremony in which Sharon de Souza will defend the academic thesis entitled Investigating Immune Cell Trafficking on the Ocular Surface and its Correlation to the Disease Stage and Treatment Outcome. Before we go to the opposition, Ms. de Souza, I would like to ask you to give us a brief overview of your major results and conclusions in a short lecture. Go ahead.
Thank you, Prorector. Good afternoon, honorable members of the Corona, Prorector, family and friends. Today I am presenting my work on investigating the immune cell trafficking on the ocular surface and its correlation to various disease stage and outcomes. The eye is a beautiful structure which allows us to see the world, and it is unique in many, many ways. The ocular surface extends from one lid margin to the other and includes various structures very important to us. If we look closely, microscopically, it has a number of structures like the epithelium, the nerves, and the endothelium. And there are a number of cells, the immune cells, like the neutrophils, the macrophages, dendritic cells, which run through the cells and move over the ocular surface. This process is called immune trafficking, and shall I continue? This process of the cells moving across the ocular surface is called immune trafficking and is extremely important in various health and disease. So why is it important to understand about immune trafficking? In the body, we have something called immunity, which is our response to any external stimuli. And we have what is the innate immunity, which is inherent to us and is automatically present when there is an external trigger. And there is the adaptive immunity, which the body develops over time. And there are various cells which contribute to each of this. And there is an overlap between this innate and adaptive immunity. Now, why do we want to understand all of this? In the body, it is not just the immune cells which are important. The immune cells and the structural cells that we were looking at work together and regulate this organ-specific immune process. In the eye, it is no different. The cells that we were looking at, the neutrophils, the macrophages, the dendritic cells, along with the structural cells, that is the epithelium, the nerves, the endothelial cells, both interact to maintain homeostasis, which is the balance of maintaining normality. And all of this is done in a very delicately orchestrated event, almost like a circus happening without us even knowing about it. So just to give an impact of what we are looking at in these cells, what does inflammation or immune stress do to these corneal cells? If you look at the left side image, the basal condition, that is the normal cells. And if you see those orange granules there, those are lysosomes, which are very, very important in maintaining the normal health and structure of the cell. However, when there is inflammatory stress or an immune stress, you can see those orange patches are much larger, much brighter. And this is the stress which is visible on the cells, and this was an experiment that we ran. So if we are looking at what is happening in the cell, just try to imagine as a car driving, the tandem between a brake and an accelerator. And in normal situations, the brake and an accelerator have a balance. However, in a situation where we are out of balance, the brake gets stuck or the accelerator gets stuck, you can have a lot of immune-related and immune diseases in the body. The eye is no different, and there are a number of conditions that are influenced by immune cells and the loss of homeostasis, including dry eye, which is so common, keratoconus, transplant outcomes, and Stevens-Johnson's or other surface conditions. And it's not just the presentation of these conditions that is different, it is also, it also has a bearing on the pain or the severity of the disease, and the various structures that we were discussing all have a bearing on it. Our knowledge, which we have about all of this, is based largely on animal studies and lab-based experiments. We do not have that much of information directly from the human ocular surface, and it is essential for us to bridge this gap in knowledge that we have. These, there are so many pieces in the puzzle that are missing, and once we try to fill this lacunae, we might be able to treat our patients that much better by understanding the disease better. So our research questions were, can we directly evaluate the immune cell subsets on the human ocular surface, and can we do this in a minimally invasive, repeatable, and a reliable method? So to go forward, what did we already have with us were tests like tear molecular factors, which we can get it very easily by taking the tears using a Schirmer strip. You can do an in vivo confocal microscopy, which is a very technical term for a test which we apply directly on the eye, on the cornea, to look at cells like dendritic cells or nerves of the eye. There's also an impression cytology, which, as the name suggests, presses on the cornea or the conjunctiva and picks up cells from that. But can we do something better? Can we have something which is easier to do, gets a good representation of the entire ocular surface, and is also comfortable for the patient? And that's where we found a group who had done the ocular surface wash, and we modified it slightly to make it more repeatable and reliable. So what is this ocular surface wash? As this animation depicts, it's very simply washing the eye of the patient using a sterile normal saline and collecting the wash with the cells of the surface into a sterile tube. What do we do then with it? We process it by storing it with paraformaldehyde and marking those cells with various antibodies and checking how many cells we have. And this process is called immunophenotyping. Again, a very complicated sounding term, but let me try to explain it a little easier. We all understand about facial recognition, which basically means we can identify a person using specific criteria like the nose or eyes, which are distinct or unique to that person. We use the same idea in recognizing cells because each immune cell has a marker called CD markers on their surface, which act as their distinct identification point. And that's what we are doing in immunophenotyping using flow cytometry. So that once we knew how we would do it, we wanted to then look at what we would find in different ocular conditions because we know they cannot be the same. And does this match with other methods which we already have with us? The first disease we looked at was dry eye because it is so rampant. It is everywhere, and it is such a varied disease, and it has become almost like a global pandemic with potential blinding complications. Based on the type of disease, we have multiple treatment options available with a lot of combinations, but unfortunately, we still don't have a cure for this disease. So this was one of our chapters where we looked at dry eye disease, and just to simplify it, the circle in the center shows ocular surface discomfort, which obviously we know patients with dry eye have, and two tests which are very common to dry eye. And I want to bring your attention to the top, where you see there are certain markers like CD45, CD66, and this is what I was saying about recognition of cells, because each of these markers tell us a particular cell. And in dry eye, we found that the neutrophils were very, very high as a proportion of the total number of cells, and natural killer cells, which is another kind of cells, was low. So there was a distinct pattern which was away from the controls or the normal eyes. And this was what we found in these patients. We also found that there were distinct differences between animal studies which were done previously, and that was very reassuring for us because that's what we started out with. So the distinct associations were not just to the dry eye disease, but also with the severity of disease and different parameters. So then intuitively, does this change when we treat dry eye? And so we moved on to our next work, where we treated a type of dry eye with what is called intense pulse light therapy, where we apply a particular wavelength of light around the eye. And very interestingly, it did change. So what we found that the IPL treatment actually increased what we call anti-inflammatory markers, the TGF-beta, which is reducing inflammation in the eye. With the treatment, this actually changed. And certain cells also came down. So again, a distinct immune profile, even after treatment. The next disease we looked at, keratoconus. Keratoconus is a disease which affects a younger generation. It is a progressive disease of ectasia. What is ectasia? The cornea becomes thinner and starts bulging forward like a thin paper. And as the disease progresses, it can become potentially blinding and in advanced cases even require a corneal transplant. So definitely something that we need to find a treatment for or a cause for. We found that even in keratoconus, there was a distinct ocular surface immune profile called an inflammatory profile. Just to make this simpler, on top you see KC grade 1, grade 2, grade 3, and that is just how we clinically grade keratoconus. Remember in dry eye, I said neutrophils were very high. In keratoconus, it switches. The natural killer cells became very high. And so we now understand that each of these diseases has a distinct profile, and we can try to map each of them with this. Another interesting point was, as the severity of disease increased, the number of cells and the number of molecular factors also changed, and the inflammatory factors, which we found, were also increased. So the profile keeps changing. And then COVID hit us. The COVID pandemic changed our lives for 2 years, but we used it to our advantage. During the COVID pandemic, most of us, as healthcare workers, were forced to use face masks for very prolonged time. And this, of course, was life-saving for us. However, a number of healthcare workers came back with eye-related problems like itchy eyes and red eyes. And this was touted to be another form of dry eye. But very interestingly, we found that the profile on these patients was totally different from dry eye. Not only did they not have any clinical features of dry eye, even the immune and molecular factors were different. And in fact, it was just their pain factors, the nociceptive factors, which were increased. So another different profile. Speaking of pain, in clinics, we do come across people who have a lot of pain in their eyes, but unfortunately, we do not see enough signs in their eye. We cannot attribute as to why they're having pain. And that is very difficult to treat if we can't see what's happening to them. So we made this grouping or classification, which is known as the DCS grouping. And we found that in the patients who had significantly high symptoms as compared to their signs, they had very high microneuromas on their confocal microscopy. So what are microneuromas? They are just enlarged nerve endings, which then stimulate pain. And in these patients, we also had molecular factors, IL-17A, which is known to increase pain. So we found a reason for why they're having pain and a better way to treat them, because otherwise it's just the tear lubricants, and they didn't feel any better. Moving one step closer to a very, very serious disease. This is Stevens-Johnson syndrome, and unfortunately, it can affect any age group. It is a condition in which the skin and mucosa all over the body peels off, and most commonly, it is a reaction to some medication, and it's a T-cell mediated disease. Please do remember that, because I'm coming to something very interesting. The body heals up, but the eyes, unfortunately, keep getting worse because of changes on their mucosa. And this is the kind of change that can happen, and it can result in blindness. And currently, we have no treatment to slow or prevent their progression. We divided them clinically to understand what were the differences across them. And very interestingly, in the acute stage, they started as a T-cell disease, but they ended up in the chronic as a neutrophil predominant disease. The T-cells were actually low. So if we are planning any targeted therapy for these people, we need to actually be looking at neutrophils and not T-cells. So this adds another option for us to treat a very, very difficult disease. So what is the impact and what is our future potential for translation? Of course, the ocular surface work now we know has been picking up a different profile across so many different conditions, and maybe we can use it routinely for non-invasive monitoring. This will help us in our differential diagnosis and prognostication, help us to harness or dampen for disease resolution. Immunomodulation, of course, is where we are heading, and targeted immunomodulation is where we want to go. Last of all, of course, is if we can find a very easy way to have a clinical immune milieu-based disease stratification. Targeted immunotherapy has gained a lot of momentum in cancer therapy, including a Nobel Prize in 2018 for their work on checkpoint immune mediation. And definitely, we need to be taking a very, very close look. We do have some options already available to us. One of them, lifitegrast, is a T-cell blocker, and it acts by reducing, acting on an interaction called ICAM LFA1. Also cyclosporin, which is so easily available, we take it for granted, but it is also a means of immunomodulation. So we need to take it one step closer. Trehalose, an easy, simple drop, has been shown very categorically to reduce MMP9 activity and is already in use for slowing down progression in keratoconus. And this image of the holotomography on the side is actually reduction in the inflammation post-trehalose use. So we do have options. And we've taken it one step closer. Personalized eye care is becoming a reality, and we now have a point-of-care kit, which is in regulatory phase. And usually, when we take the tears, using the Schirmer strip. It goes into the lab, we have to do an ELISA, and it takes a few days, if not longer, to get the results out. But we want to do it faster. We want to see it, directly help our patients. So this is a point-of-care diagnostic kit where we can collect the tears and then put it into a cartridge, which can give a readout in 90 minutes and give us values of certain, a whole parameter of different immune cells and inflammatory markers. And then we can use this to try and treat our patients better. So with that, I end my presentation. Thank you very much to my supervisors, the Corona family, friends, who have been so supportive, and I really wouldn't have been here without you. Thank you.
Thanks a lot for this beautiful presentation and enthusiastic presentation also. Your supervisors have selected a group of specialists that have assessed your thesis in a positive way. They were positive about the data presented in your thesis, but there are always questions that remain. We have 3 opponents on site, and we have 3 opponents online. By the way, I think I have to ask the opponents online to mute their microphone because there's some echo, if possible. But we'll start the opposition now, and Professor Shiri Spertlov will start with the opposition. She's a professor of genetics and cell biology at this university and was the chair of the assessment committee. Please, Professor Shiri.
So, dear candidate, first I also have to compliment you for a very clear presentation and mainly for your passion. It's great to see. And also for your thesis book, which I read with a lot of interest. I also want to extend my congratulations also for your promotion team. It's a beautiful data set that you have. You've demonstrated very nicely the diversity in our immune cells across different diseases. And definitely you can develop it in the future into a targeted therapy and a more accurate diagnosis. So compliments for you.
Thank you,
And since the eye is not really my field is more the metabolic syndrome. This is where I would like to start the discussion from. I want to ask you, what is then the link actually to a more systemic inflammation? Do we see some possible links in terms of not just the associations and correlations that is there, but also in terms of treatment options? Are some treatment that are more systemic for metabolic diseases are working, and or nutritional intervention? Anything that you can say about that?
Yes. Thank you, highly esteemed opponent. Yes, that is an excellent question, and we do have actually work running on it already. It was just outside the scope of the discussion. So there is definitely a link to not only our systemic disease and metabolic disease, but everything from what we eat to our environment. And we have shown that in various studies. So for example, in patients who have allergies, okay, and that's very, very common in children and adults also with keratoconus, we have found that patients who have systemic allergies, even if they do not have an actual visible clinical allergy on the eye, they still feel like itching their eye, even though I can't see any allergy. And that is because the systemic allergy is actually triggering the eye. And we actually did a study, and we published it, to show that in these patients, their systemic allergy is actually making it release certain factors in the eye, simply termed itch factors, that make them rub the eye in spite of the fact that there's nothing visible. Another very interesting example is patients who have diabetes. Even in them, though it's not directly related to the eye, we can see changes on their confocal microscopy in their corneal nerves. And we do know that they can have certain neurotropic changes where their sensitivity on the cornea is lost because of the diabetes.
So you think it makes sense to maybe subgroup your patients
Yes.
into different categories?
Absolutely, absolutely. And I think the strength of any of this work, as I was mentioning, even we club everything into, say, dry eye. We found so many variations in dry eye itself or any disease. The more we clinically subclassify and subphenotype them, we were able to find much, much more definition in our understanding and probably a better way of treating them. rather than grouping them.
So also from a systemic point of view, you envision a treatment in the future.
Absolutely. So even when we're looking at, say now, there's a lot of work going on in Alzheimer's and dementia as well, and they have found that there are secreted molecular factors in the tears which can predict the onset of Alzheimer's, and even some studies are saying about breast cancer. So definitely trying to systemically look at them, and some screening tool may come up from the eyes. So.
Nice. So your book, actually, one of your novelties, that you close the gap between till now, that was a lot of studies that were done in animals, and now you're doing actually with this cool technique, you do that in humans. And you mentioned now also in your presentation that the results were quite different from what was found in the animals. Maybe you can elaborate on it, but also tell me what is exactly has been changed. But isn't that not related to the methods that you have used because in the mice you can also... Okay.
Absolutely. So, for example, in our work on dry eye, we found that in the animal models, they found a very high preponderance of macrophage and gamma delta cells, whereas in the human ocular surface, we did not find such a high preponderance of them, or at least a significant preponderance of them. Contrary, we found a very unique association between neutrophils and NK cells, an inverse relation, which has not been described before in animal studies. And it almost seems like in this condition, NK cells, the natural killer cells, may have a protective role because they seem to have some sort of a inverse correlation when it comes to clinical features. Definitely, there can be, this could be because of the methodology. And it's totally different. There's no way we can wash the mouse eye. So to collect the immune cells, it's always an impression cytology.
It's not possible. I was just about to suggest this.
We could try. I haven't yet, but we could try and do it. I'm not sure how much we'd get, but I would love to try it. But up till now, the animal studies which are there are based on impression cytology and tear extracts.
So, I mean, what should we do now with the animal work? Should we just neglect it, or should we then still, do you see some...
No, definitely. The animal work has built our knowledge. So it's not that it's completely different. It's not at all completely different. But there are a few variations.
With the differences there, like, do you think you can maybe use the mice to sort of like check your approach? Because
yes, absolutely. So one way, and we are starting animal studies for some slightly related work. So we did the experiments in the lab, then we've done the immune cell wash, and we're going to check by stimulating particular cells in the animal model to try and see if the results then close the loop. So animal models still have a very, very important role to play, and they form the basis of what we have learned till now. So definitely cannot push it aside. We're not yet there.
Okay, and do I have time for a short question? So just like if you would now take a next step towards translation, what would that be? Which challenges do you see there?
So we do have some interesting drugs which are available to us, and repurposing of a drug is much easier than getting a completely new drug. So there is IL-6 receptor inhibitor, there are ICAM inhibitors. The challenge with any targeted immunomodulation is that when we try to modulate a single molecule or a single cell, we do not know what effects it's going to have upstream or downstream. So that's always a challenge. So we have to find that critical point, and I think that's where checkpoint inhibition won, because they found a critical point where it really makes a difference. So we'll have to find that. You can't just take any model. So that would be for a particular disease, try to find that.
Thank you very much. I'm very happy with your answers, and I bring the discussion back to the prorector.
Thank you.
Thank you, Professor Svetlov. The opposition will now be continued by Professor de Boer. Professor de Boer is Professor of Ophthalmology at the University Medical Center in Utrecht. Professor de Boer, please go ahead.
Thank you. First of all, I would tell you I'm impressed by your work and also by the presentation. So I want to congratulate you with this nice thesis and also your promotion team. Currently, a trauma helicopter is trying to land on my roof. So maybe there is a little bit of background noise, and I want to apologize for that. I'd like to have a discussion with you about what you tell in your introduction. In your introduction, you mentioned that inflammation plays an important role in the pathophysiology and natural history of several acute and chronic ocular surface diseases. And then you mentioned Stephen Johnson, pemphigoid, ocular allergy, corneal graft rejection. And I think, in my opinion, these are all primary inflammatory diseases. And I wonder what you think about the dry eye diseases. Is it primary an inflammatory disease, or do you think that the immune system is secondary involved in the pathogenesis?
Thank you, highly esteemed opponent, for that wonderful question and comment. So I think in dry eye disease, it is a little bit of both. It is a primary inflammatory disease. Definitely, inflammation plays an important role in the etiopathogenesis of dry eye, irrespective of the etiology, whether it's an evaporative or an aqueous deficient or related to a cicatrizing disease. However, there is a sort of a vicious cycle which runs in dry eye. So the immune system also gets triggered by the inflammation. And of course, if there is an external stimuli, like in conditions of cicatrizing disease, Stevens-Johnson's, or even if they have an underlying connective tissue disease like rheumatoid arthritis, Sjogren's syndrome, then definitely the immune system has a very, very important role to play, because unless we control that, and we've seen that clinically in patients as well, if we do not control their systemic immune system, in rheumatoid arthritis or Sjogren's syndrome, their dry eye just does not get controlled, and the ocular surface continues to worsen irrespective, even if we give topical immunomodulatory therapy like cyclosporin topically. So definitely an overlap of both inflammation and immune contribution from the immune system.
And I wonder what is the trigger if the immune system is primarily involved in the beginning of dry eye diseases? What is the trigger then? Is it the tear film is disrupted? So is it are the microbes that are on the ocular surface, or is it the epithelial, the little lesions of the epithelium? I wonder what is the primary trigger.
I think across both the existing literature that we have and our work, for each type of dry eye disease, I think the trigger might be a little different. So in conditions like meibomian gland disease-related evaporative dry eye, we do know that the meibomian gland secretions can tend to get a little infected, and there can be some amount of microbial population there which is lodging and increase the inflammation. So that could be a trigger in evaporative dry eyes, because that then blocks the secretions, changes the quality of secretions, and then changes the quality of the tear film, which then breaks down and causes the dry eye. Whereas in a condition like Sjogren's syndrome, where because of the involvement of the different glands, the lacrimal gland, the other secretory glands in the eye and the body, there the primary problem is an immune problem. The secretion of tears is reduced from the gland itself. So there the aqueous component of the tears is reduced. The tears are not adequate enough to cover the ocular surface. The ocular surface then desiccates because it is not covered well. That desiccation then leads to the epithelial cells being under stress. The stress would lead to them releasing various cytokines and inflammatory factors. The inflammatory factors which would then call in the immune cells, they would release more inflammatory factors. So I think for each type of dry eye, the trigger might be different, but of course there's so much we need to understand still. I hope.
Okay, and you found, you already mentioned that you found the neutrophils in patients, and not in the animal models, but in patients you found the neutrophils and the natural killer cells. And when I look to figure 2 on page 58, it looks like that there are more neutrophils in aqueous deficiency compared to the evaporative form of dry eye disease. And my question is, how can you explain that? Is that the aqueous deficiency is more severe, or is there a different pathogenesis between both forms?
Yes, that's a very interesting observation. We looked into exactly this even when we were analyzing the data because, as I said, otherwise we just group dry eye into one big umbrella. So the aqueous deficiency dry eye definitely were patients who had more severe forms of dry eye. And these are patients which very often have a lot of staining on their ocular surface, much more than the evaporative. Their eyes which are more inflamed, they look red, the patients are more symptomatic. So definitely in terms of severity, they are in the scale of severity, there are patients who have more severe disease. That could be one reason. And as I was mentioning, they are two different entities in terms of how they develop and the etiopathogenesis. So that could also be one of the reasons. But I think the neutrophils are just pointing towards an immune profile. We'll just have to look at larger subsets, different more variation in the kind of dry eye patients we're looking at to really pinpoint what's going on.
And can you speculate that it is the innate immune system that is involved because of the neutrophils, or do you think it is more an adaptive immune response in these cases?
Very briefly answer the question.
Yes. Intuitively, we would say since the neutrophils are there, it must be the innate immune response. But across all of these diseases, we have found a strong overlap between the disease profile. I think a lot depends on which stage you catch the patient, and all of them, I think, move across the spectrum. So a lot would depend on where you see the patient.
Yeah, you see it changing over time, the inflammatory cells on the ocular surface. Is that what you mean?
Change from based on the weather, based on the patient's, what time you're taking it. And of course, if they are in that phase where it's a very inflamed surface or they're on treatment or what, so they do change a lot.
And when we look to the future, can the cellular infiltrate on the ocular surface? Could it predict which treatment would be suitable for the patient in the future, do you think? Would it be one of the diagnostic tests in patients with dry eye diseases?
Yes, I do think, and actually in our clinics, we're already trying to do that to an extent based on the kit which we have developed and also on the immune cell profile. And we're trying to cater whether a patient would do well with intense pulse light therapy or they need cyclosporin, and we are getting lifitegrast soon, so whether that would help them. So definitely we are moving towards trying to cater treatment to each patient, yes.
Professor de Boer, for your questions. Thanks a lot. We have to continue, I'm afraid, to give the other opponents also a chance to ask the questions. The next opponent will be Professor Bouchard. He is a professor of ophthalmology at Loyola University in Chicago. Professor Bouchard.
Thank you, Prorector. First, to the candidate, I'd like to commend the rigor and quantitative standardization of your non-invasive diagnostic approach to understand the interaction between molecular factors and the many immune and structural components. Because of the clarity of your work, I have actually had all my residents read your papers on dry eye and keratoconus, and I think you've helped them tremendously. I have a couple of questions. One is a fundamental question, and that, you mentioned as one of your limitations of the work that the ocular surface wash technique really identifies a superficial and trafficking cells and not necessarily the embedded cells deep in the mucosal tissue. So, but unlike other diagnostic approaches, the ocular surface wash does provide a broad assessment of cells and mediators. Can you comment on this limitation?
Thank you, highly esteemed opponent, for your wonderful suggestions and comments. So yes, I think that is definitely a limitation that we've mentioned. there are a number of cells which are embedded. They're not embedded very deeply into the epithelium, but definitely embedded. And the wash for sure can only pick up very superficial, either the ones which are on the surface or slightly embedded ones. So that's definitely a limitation. We have over, the different work that we've done on different papers, we've tried to compare. We did have a paper initially where we tried to compare the results we got from impression cytology, which is able to get the cells which are embedded, to the wash sample and the results we got there. However, it is logical, they are both looking at two different subsets or samples. One is a very localized sample and one is a wash of the entire surface. So we didn't really find that they were comparable. I think if we really want to make it stronger and if it was feasible, the ideal thing would be to do both in every patient. Then you could get the embedded cells and the wash. However, it's not really easy to do both this. And the idea was to try and get something beyond the impression cytology. But that would be ideal. But we've not found... So going forward, I think if we manage to get larger samples and do longitudinal studies of patients, these are most of them are cross-sectional work. So if you could get longitudinal work, or I'm looking at doing wash across different times in the day to see, or different, in different situations, that may then fortify or strengthen the data we're getting out of the ocular surface wash.
I mean, the benefit, of course, is that you're really covering the whole surface. And in impression cytology, you're only taking at one section. And a lot of microbiome work demonstrates a biogeography, that the upper fornix, the lids, the whole, the ocular surface can be very different. So that makes it a little challenging. Another limitation, and I would broaden that you bring up, is the racial and ethnic a contribution to disease variability. And I would extend that to really looking at control subjects. I mean, as has been brought up already, people with diabetes, autoimmune disease, if you take their inherent systemic condition and then you look at their ocular surface disease, there's certainly would think to be a relationship there. So you really got to pick the control subject to really look at the controls very carefully. What do you think about that?
I think it's absolutely true, and it's very, very important. And we've been as rigorous as possible with taking our controls, and that's quite difficult actually, because the different papers and different diseases are across different subsets. So keratoconus, for example, are relatively younger patients, so it's easier to get say our what we consider normal, so who do not have any other disease, don't have dry eye, don't have other systemic diseases, it's easier. But when you take a condition like, say, dry eye disease, which very often has a slightly older age group, then it becomes that much more difficult, because they are patients who could have systemic disease. We have tried in our controls to exclude those who have a history of any systemic disease, so controls, but we do know that they may be undiagnosed, or they may not know that they have a disease, so that's always a challenge. But yes, to the extent that we've actually, on patients who do not have symptoms of dry eye, we've still checked to see if they have dry eye, even if they don't have symptoms, to make sure that they are as close to a normal control as possible. But it cannot be undervalued, I think, the importance of a control, because it makes or breaks your data in terms of what you get out of it. So it's absolutely essential.
Now, when the other more couple of detailed issues, the NNKR, the relative, you mentioned that in a lot of different areas, but is it that the neutrophils are elevated more than the NK cells are decreased? So if you have elevated neutrophils and the NK cells are the same, you're going to have an elevated NNKR. How does the NNKR add to this diagnostic signature more than just elevation of neutrophils?
So I think we were more looking at the ratio having a sort of a causal a clue, rather than it being an actual diagnostic signature. The signature still remains, which type of cell you see. But because we found that ratio the neutrophils high and the NK low, we are trying to take it a step forward to see if there's any protective role that the NKs may have in certain diseases, and that's what we were exploring there, rather than saying that you see that ratio and you're actually trying to make a diagnosis of it. So because having these cells in isolation don't really do anything unless we take it forward and try to figure out how it extrapolate or see the association clinically and what it means to us clinically. It has no value. So that's what we were trying to do with that.
I thought it was the whole discordance between signs and symptoms. I really enjoyed that chapter in your work, and I don't know if you have any more thoughts on that. It's a very difficult, and I know that trying to quantitate all these values of cells and soluble mediators, it's a very challenging goal. Can you comment on, I guess, any future ideas about helping us with the discordance between signs and symptoms?
Can you do that very briefly? Yes. Thank you.
So all this work is ongoing. So yes, we have taken it one step further. So with this work, we are now looking at treating these patients, and based on whether it was just their microneuromas or they had IL-17 high, we did look at treating them with autologous serum. In some patients, they did well, intense pulse light therapy, and some who had what we call a Parakine challenge test negative, and I'm sure, Professor Bouchard, you're familiar with that. We did find that they needed a reference to a neurologist to treat, and they did extremely well with systemic medications. So we have looked at them, and we're trying to now subclassify that group of patients even further and see who benefits with what treatment. So these are
great. Very exciting work. Really enjoy it.
Professor Bouchard. The opposition will be continued by Dr. Wieten. Dr. Wieten is assistant professor in transplantation immunology at the Maastricht University Medical Center.
Yeah, thank you. I want to congratulate you with your beautiful thesis and also your promotion team. And your energy is inspiring, and it also really reads through your thesis that you really want to help those patients. As more a basic immunologist, I liked it. I have always learned the eye is immune privileged, but you really encouraged me to dive a bit more into detail in the immune system of the eye. And before we discuss that, I have a few very short practical questions about how you identify your immune cell subsets in the flow cytometry gating. In some chapters, you identify NKT cells based on the presence of CD3, CD56, and CD16, and in others you do not include CD16. Why did you do that? As far as I know, CD16 is not really a typical NKT cell marker.
No, I think it was more to do with the fluorescent antibody which we had from the company at that time, rather than anything more technical than that. But yes, for all intents and purposes, it is the CD3, CD56 that we were looking at. So
okay,
that would be.
Yeah, and for your identification of NK cells, you took CD66B negative, CD56 positive cells, and did you also exclude CD3 there?
Yes.
Yes?
Yes.
Good. Okay, I couldn't really see that. I already thought so. But yeah, otherwise because you had quite a lot of NKT cells there. Yes. Okay, good. Happy to hear that. I would like to discuss a little bit on tolerance in the eye with you. Because you very nicely show that there's, for example, an increase of CD4 and CD8 T cells in inflammatory eye diseases. And what I was wondering, did you have the opportunity to immunophenotype them a bit better, perhaps in alternative studies, and look, for example, at regulatory T cells, because the balance between those can be very important as well?
Yes. That is an amazing question. Thank you, highly esteemed opponent. So we did look at it. The Tregs are very, very important, and especially in cases where we're looking at graft rejection and corneal graft-related disease. And we do have work going on for that. It didn't make it to part of my thesis, but it is ongoing, I think. So the T helper cells, the T regulatory cells, we have looked at it, and we are trying to subclassify as much as possible, because there it would be absolutely essential for us to look at the subtypes, but not here.
And if you then, because in, for example, dry eye diseases, you see an increase of T cells on the corneal surface, and what do you think is the reason for them being increased? Then what is driving them?
So I think in dry eye, we start off with the neutrophils being elevated, but as the chronicity of the disease increases, if they are untreated, then it goes into a vicious cycle of inflammation, and that then triggers and goes into the more adaptive stage, and that's where the T cells come in more in response to the structural and epithelial changes which may be happening, or the desiccation on the surface that may be happening, and that's in response to that. So it doesn't happen in the very early cases, but over time, and many of them are chronic diseases, chronic patients. So if they have not been well treated, or they've had the disease for a very long time, then you do see some amount of T cell as well on that.
And do you know, are these T cells antigen specific?
I'm not sure of that, but I could look into it.
Is there sort of an autoantigen involved, or not known?
Not known, no.
Okay,
no.
Okay. I was thinking, what more can we learn from other tissues where tolerance is, of course, very important? And one of the things that strike me is that I come more from the cancer immunology field, where you already refer to the targeted immunotherapies, the checkpoint inhibitors. And I think one of the things that we see with some of those patients when they're on therapy is that they develop dry eye disease. Yes. What do you think about that? Is there a direct relation? Is it coincidence?
Right, so a lot of patients on chemotherapy do develop what we call graft versus host disease, and that presents with extremely severe dry eye in these patients.
Sorry, I was specifically referring to the immune checkpoint therapies, where anti-PD-L1 or anti-PD-1 are used.
Okay, so I have not come across anyone who's been on that specific treatment, but definitely extrapolating from what I have my clinical experience with patients who have been on chemotherapy, that it will definitely be some form of an immune-mediated dry eye itself, because there is the immune response will be there to the lacrimal gland, to the conjunctival goblet cells, and so they do come back with a lot of aqueous deficiency dry eye. The similar thing has also been seen in radiation therapy, even though you didn't ask, even if they've not had radiation closer to the eye, but they can have a response in the eye. So I think almost like our lymph nodes or other organs, we do have some amount of immune cells there which respond irrespective of where the systemic insult is. That would be a hypothesis, just a disclaimer.
Okay, I think it would be very nice to study expression of those molecules in the eye. I'll give the word back to the project.
Yeah, thank you, Dr. Wheaton. Because of time, we have to continue, I'm afraid. And the next opponent will be Professor De Smet. He's professor of ophthalmology at Mount Sinai University in New York. Professor De Smet.
Thank you very much, Dr. D'Souza. It's a pleasure to be able to talk to you about your thesis. And as others have said before, congratulations on this thesis. It's very well written. It's clear when you read your articles. In fact, if anything, you're sort of driven into reading through the whole text to the very end. It makes it easy indeed for residents to be able to read this, because I can remember days reading articles and falling asleep, but this is definitely not the case here. And I would also want to thank your whole promotion group that have made it possible for you to get here. This being, of course, a thesis defense, we have to be able to discuss on a few things. And I'd like to get back to chapter 3, and if we have a bit of time, to chapter 4. So chapter 3, you talk about your results by doing the eye wash. And you mentioned in your presentation that it was more reliable than, for example, the existing technique, which essentially looked at collecting cells and fluid at the very beginning of the day after a person wakes up. In which way is this much more reliable than what has been done in the past?
Thank you, highly esteemed opponent, for your comments. So the previous studies which have discussed the ocular surface wash did what is called closed eye sampling, which basically they gave the material to do the wash to the patient, and they used to, the minute they get up from sleep, they used to do the wash themselves and bring the sample to the clinic. Whereas what we've done is an open eye sample, which basically is done in the clinic under standardized conditions by someone who's trained to do the thing, even though it's a very simple wash, but still you can have discrepancies if a lot of the wash flows out, if you're getting too much wash onto the eyelids, if you contaminate the wash. So those kind of things, we do know about the microbiome or a lot of contamination from the lids and lashes. So in that way, the technique of collection is more standardized. Of course, those are beautifully and very well written papers, and our work is based on that idea and that concept. So definitely not necessarily better than what they collected, it's just done differently.
Well, I certainly commend you on trying to do it this way, because I think it will give more information. But then the next question is the following, and I think it has bearing on your results also, is wouldn't it make sense to first sort of wash off the surface of the eye, potentially wait for a period of time, and then after that do your eye wash collection, so that whatever is present is not just a collection of cells that are on the surface and aren't being eliminated, for example, through the canaliculus? And have you looked into that? And would that make a difference in terms of your results, and maybe also increase the difference between your evaporative versus your aqueous deficient group?
That's a really interesting suggestion, actually. We haven't done that, but I don't know if we do an initial wash. We are actually trying to collect the immune profile at whatever X period of time. And if we wash, so that could, in a normal scenario, in a normal patient, we expect it to have some sort of an influence from external, influence from the lids, influence from various factors. So washing off, removing the first wash and then waiting for some time, I do not know if it would give us a real picture. But I think it's a great suggestion, and I'll definitely do it in a subset of patients and see what the variation is. I think what would be more crucial would be to see what time gap we leave between the two washes, because too early and we're not going to get anything, and too late, then we are back to square one. But what we do definitely is to have a look at the patient before we do the wash to make sure they don't have any evidence of infection or crusting on the lids or anything else, which would obviously contaminate the sample. But yeah, great suggestion. I will definitely look into it.
Okay, so we have to move forward. So I want short answers, because in your chapter 3, you have 15 patients that are controls, 22 are experimental. Your control is on average 29 years of age, and your patients are 45. What is the influence of age on the cell population and cytokines that you might be able to collect? Aging has an effect on everything in the body, including cell immune function. Is this a factor here or not, according to you?
Yeah, it definitely is a factor. However, the age range, if you see in the patient profile, is a little wider than the controls, and that's why probably the average has gone up. But other than a few who are in the extremes of age, which has then pushed the average up, most of them are closer to the controls. We just included them to try and get a better clinical profile. But yes, we would want the age range to be as close to the control. So it is a little wide, yes.
Because that's something to look at also, is the variation in normals over age, so that you have better controls in the future. And then when we look at several of your figures, including figure 6, for example, we don't see that much difference between the groups, but I wonder to what extent dry eye itself, your evaporative have good Schirmer tests, your aqueous deficient obviously less, you have symptomatic patients, they're the ones with more cells. have you tried to correlate the amount of cellular findings that you have with the amount of tear production that each of your patients had? It's not an analysis you've done here, but it might be a very interesting one to try and put it in proportion with regards to what are you really collecting in these cases?
Again, because
yes,
of
I
the
will
time,
keep it very
please
short.
speak.
I will keep it very short. So definitely the ones who have more severe disease and the aqueous deficient, we did collect a lot more cells. But as you rightly suggested, a lot of them were epithelial cells and debris, and the proportion, the number of immune cells we got would be significantly less. So we did look at that. And in the two aqueous deficient and evaporative, the number of cells are more or less similar, but I think we collect much more epithelium and debris in the aqueous. And that could be due to the severity of disease.
So maybe we have to correlate that also with regards to what you're finding, is to mention the epithelial debris, which you did not in your paper. So one last very final question, if I may, has to do with chapter 4 on IPL, a very hot topic these days. And, you know, I'm left a little bit here with your finding some improvements in these patients, both on symptomatology, but virtually nothing with regards to the findings here. So is it really an improvement in terms of nerve function inside the cornea that is really a role here? And how would you try to elucidate that?
I don't think I got your question.
Sorry, if we look at, you see significant improvement from the symptomatic standpoint, OSDI, for example, in your patients treated. We don't see a great difference in terms of the cytokine changes. They're still about in the same type of level. Maybe a little bit of a signal, but I would think that most of the effect you're seeing here is from another nature. Is it not just that they feel better, and therefore it's the interaction with the nerve endings and the nervous system? Certainly that has been raised on several occasions.
Yes, so it could definitely be related to changes in the nerves. Maybe if the epithelium improves, the exposed nerve endings, they're not so exposed, so they could be better. But I think more than the overall cytokine profile, which seems more or less similar, it was a few of the pro and anti-nociceptive factors which showed a more predominant change, and the balance between the pro and anti-nociceptive factors is what we felt was driving their symptomatic relief.
Okay, great, thank you.
You always have to be careful that you're not looking. Okay, I'll stop here. We can have a discussion at another time. Thank you very much.
Yes,
And
I
give
will
back
look
the
forward
word
to
to
it.
the rector.
Thank you, Professor De Smet. Opposition will be continued and finalized by Dr. Erkens. Dr. Erkens is ophthalmologist at the University Eye Clinic in Maastricht.
Dear candidate, I also would like to congratulate you and your team, your promotion team, on your impressive work. And I will try to ask some fast questions too. In chapter 9, page 174, you state that keratoconus has a strong inflammatory component. And should we then start earlier with immune suppressive therapies?
Right, thank you, esteemed opponent, for your comments. Maybe not immunosuppressive therapy, but in keratoconus, we do know because of the inflammation and the allergy on the surface, starting early with treating them, and we do that in our clinics already, is to try and treat whatever inflammation. And most of the inflammation there is due to their allergy or their rubbing. Yeah. So we do treat them early, treat the allergy quite aggressively with whatever we have. So we do have mast cell stabilizer drops, we do have cyclosporin available to us. Now trehalose has been found to be very useful. So we do treat them aggressively in the initial, at their presentation, to try and then follow them up and see if that has helped to reduce their risk of progression. And the great thing is that, yes, it does. For a lot of people who stop rubbing or their allergy reduces, inflammation is reduced, their progression does slow down, and we may not need to cross-link them. So need not be an immunomodulation in that sense, but this kind of immunomodulation, yes.
So and start earlier, earlier in the disease.
Yes.
Okay. And you as a cornea specialist, and I'm as a uveitis specialist, sometimes we see the macular edema, which reacts also good to tocilizumab, an IL-6 blocker. Yes. And I also see that IL-6 comes a lot in your study.
Yes.
Did you see patients who were on tocilizumab, on IL-6 blockers, and improve or get worse or something like that?
No, unfortunately, I've not had patients on tocilizumab because ours is a standalone eye hospital, and not many of our uvea specialists have used that systemically or even topically. But yes, we were looking to sort of repurpose the drug to see if we could use it for because we have IL-6 raised in many of our studies. So definitely we were looking at it as one of our potential targets. So, but I have not used it in any of my patients, yes.
And what would we learn from each other, or what data would we like to collect for each other? I mean, as a uveitis specialist and a cornea specialist, I think we look at eyes, but we miss sometimes things from the other one, but we don't write down. And I think we can learn a lot also when we treat patients, if the cornea is getting better, or maybe the macula is getting better, or the uveitis. You think we should more standardize our investigations and our treatments or something?
No, it's just I think the examination of the eye, we must remember that as we examine it as a whole, as cornea specialists always look at, we should be looking at the anterior segment reaction. It saves us so many times in patients who have early graft rejections, because the early AC reaction is what gives us the clue. And again, as uvea specialists overlap in patients who have children who have rheumatoid arthritis, juvenile rheumatoid arthritis, they may come to us with melts. They actually have something which is in the uvea. So definitely a lot of overlap. Similarly, in patients who have ocular surface disease, the pemphigoid and conditions like that have a lot of overlap with the immune reaction. So I think there's a lot of work that can be done together.
I thank you for your answer. I give the word back to the prorector.
Thank you, Dr. Erkens. Ms. De Souza, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and the quality of your defense. And I request you and your company to await the results of our deliberations here in this room.
Thank you, Prorector.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Southside, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Ms. de Souza, the degree committee here present has assessed the quality of your thesis and the quality of your defense, and in view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Dickman is authorized to confer upon you this academic distinction in accordance with Dutch university customs. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confirm upon you, Sharon de Souza, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of Maastricht University.
Dr. Sharon, it's a great pleasure to see you defend this wonderful work, which has given you a lot of passion and drive, which you always wanted to do. I remember 6 to 7 years back when you had come, Sharon was she did her cornea fellowship with us, and I'd known her from the time she was MBBS student. And she has had that drive which was always very infectious, and it brings in a lot of drive in a lot of people with whom you work with. When she finished her training as a cornea surgeon, she asked me, what do I want to, what should I do, how should I take it forward? I told her one thing, that you should do something which should make one day your son proud, and you should make yourself proud. And today you made him proud because he saw something, and that's all it is. You completed the journey. When you see a child being so positive about somebody doing work which probably he didn't understand today, and your parents who have been your strength and with whom you've derived a lot of positivity and drive. And before I start my small just about what you did, thanks to your husband, Amit was my we studied together, and he's a very renowned spine surgeon in Bangalore. His area of specialty is complex spine disorders, and the kind of flexibility he has given for you to work. I think these are the people who have given you uninterrupted time to make this possible. See, when you talk about great work only happens when there is an environment at home which makes you concentrate on this. So before I say, I think a big thanks to all of them for making you so passionately involved in the work, and everything was taken care by them. There is, so when we decided to pick up this thesis, ocular immune trafficking, 3.5, 4 years back, the minute we started working on the thesis, COVID stuck. We had, in a way, if you go back to those days, sometimes everything happens for good. And there is a very famous Chinese story about a Chinese farmer who loses his horse, the only horse which is for livelihood. And somebody goes to him and said, "You lost the horse, so your life is gone." So he says, "I don't know whether it's for good or bad." After a few days, the horse brings in 5 horses to his farm, and then everybody said, "You're a lucky man." And the man still says, "I don't know whether it's for good or bad." Because there are 5 horses, his son jumps on a new horse and breaks his back, for which Amrit is treating. So again, people say it's a bad luck. So he says, "I don't know if it's good or bad." Finally, there's a war in that province, and the army comes to pick up all the men in that area who are able to run the army, who are ready to join the army. Only this person was not picked up because he had a spine fracture. And they lose the war and all the men die. So again, it's for good or bad. So we don't know. The story continues like this. So the reason I said this, we never know why we took this topic. And we have reached the stage where, when I was speaking to all the committee outside, they really loved the way you worked, the way you connected your work. And the most important part of any thesis is that this should connect to patients. Many times we create great books, but we never create any translation to the patient. There are 3 things which Sharon has and her team has done. One is they found a diagnostic tool which is useful, which can be used by anybody today. 2, you've created from your thesis work and work done by your predecessors who have worked on it, Dr. Pooja, Natasha, and everybody else, that you are bringing a kit which you can do the tears and analyze and give it to them. That is, again, something which is transformation or translation. And the third is you spoke about new drug delivery system, which I think you're working on it. So as we speak today, Sharon is working on the stem cell, iPSC stem cell, for creating non-transplant corneal change and changing the endothelium through blood. You're bringing, you're cultivating the pluripotent stem cells to create for endothelial dysfunctions. So it just means to say that her PhD work is just a question. It's just a comma, not a full stop. And I'm sure we will see her guiding many more generations of PhD students, and we'll have many more theses as worthy as this. And when people say that, well, immunology is something, there are very renowned experts of immunology out here. One of the biggest challenges we both have seen, and you particularly, is the clinicians don't consider immunology as important aspect of anything. The clinicians consider immunology as just a byproduct which is to be forgotten. But you picked up the immunology, you picked up the science of what immunology can be translated with your help of all the team members who are watching you, your colleagues, your postgraduates, the lab people, Dr. Arka, Swami, Abhijit, and all of them who are watching you. I think all of you created something where you can translate to every single clinic as we move on. And you strongly believed with your team, which is very important, that the foundation of immunology helps to treat, understand, and maybe predict what's happening in your eye. And this will take to the next level of trying to predict what's going to happen in cancers and other things. So I end my talk with, again, a story about when people say that we don't need to know this, we just need to, as surgeons, we just need to treat, we just need to operate. It's a story of a farm where there is the lady of the house keeps a mouse trap. The mouse runs outside and tells all the other farm animals that there is a mouse trap, be careful. All the farm animals say, it's your problem, the trap is for you, and we are not bothered about it. The same day, the night, The lady of the house comes to look at the trap. There's a snake which bites the lady, and lady is taken to a hospital. And when you take to the hospital, the person in the hospital, the doctor says, get her a chicken soup. So he goes back, he culls the chicken and gets her the soup. The one animal is out. The second day, he says to sacrifice a lamb. Second animal is gone. He has no fees to pay the doctor. He sells his cow. Like that, the whole farm is devoid of all animals because all are dead. And finally, the only thing is left is the mouse. So the moral of the story is, when people say that it is not, I don't want to know about it because it's not my domain, imagine that one or the other day it will hit, everything gets hit to you. I'm sure the work you created with genetics, or the immunology, and the microbiome, which is one more big arm of work which is happening, is just like this story. So you have kind of explained to the people, clinicians, that the work of all this is as important as doing a great surgery. On behalf of the supervisor, co-promoter, and all the committee here, we congratulate you for your wonderful work. And Professor Rudy asked me, is she going to continue? I said she's already a consultant and she's working on iPSC cell line. If we get a good candidate, we might register for a PhD. She might be the guide. And both your parents for instilling the value of courage, resilience, and being very dignified in all during all ups and downs. And Amit for being whatever he is and giving you the strength to create this wonderful work. And I'm sure this is going to continue. And your young boy out here will one day probably remember this day, and one day he might be doing the similar thing. And that's probably the best thing you could do, is to inspire him today. And TOS and all the department for giving you a wonderful background, wonderful support whenever needed, and more for being everything. Thank you. And thank you also.
Dr. D'Souza, it is a great honor for me to congratulate you on behalf of the university, on behalf of the Board of Deans of this university. I also would like to congratulate your supervisory team, Dr. Dickman, Professor Neutz, and Dr. Shetty. Thank you for the beautiful stories. And of course, I would like to congratulate your family, your parents. You can be very proud of your daughter, which I'm sure you are, your husband and your son. Congratulations. Did you like it? Yeah, very good. Well, we were very much impressed by your presentation and your defense. And I certainly hope, and I hear that there is a chance that you will be involved in future research on this topic, together with the Maastricht University. So having said this, I close this ceremony, but I would like to ask the audience, which I also congratulate, because I understand, and also those that have been involved, others that have been involved in your studies, because research you never do alone. There's always a lot of people involved and patients. I would like to ask the audience to wait in the rafter to congratulate the new doctor, and we will make some pictures here first with the external opponents, and then we go to the stairs of in the hallway, also to make some additional pictures, and then we go to the rafter. Yeah, thank you.
Recording stopped.